Welcome to the deep dive. Today, we're getting into something huge, a massive demographic shift happening globally, but maybe nowhere more intensely than India. We're talking about the aging population.
That's right. It's a really critical topic.
And we're going deep into how India's tackling it, specifically looking at their national program for healthcare of the elderly, the NPHCE. We've got the details on its structure, its aims, how it's actually working out on the ground.
Yeah, the source material gives a pretty comprehensive view.
So our mission today, to really understand how a country like India is proactively dealing with the unique health challenges of its older citizens, looking at the strategies, what's working, and, the inevitable difficulties.
And, from a public health standpoint, this is fascinating. It's not just India's story. The UN's predicting, 1 in 6 people worldwide will be over 65 by 2050. That's huge.
1 in 6, wow.
Right. So understanding a program like NPHCE isn't just academic. It's vital for anyone thinking about future healthcare anywhere.
Okay, so let's zoom in on India then. The numbers there are pretty dramatic on their own. The elderly, so that's 60 plus, went from about 8.6% of the population in 2011 to nearly 10.5% just 10 years later in 2021.
A big jump already.
And the forecast for 2050, they're saying maybe 19%, almost a fifth of the population.
It's a massive shift, and it brings complex health issues.
Exactly. I saw it described as a triple burden that older people often face. What does that actually mean in, public health terms?
That triple burden is precisely why a dedicated program like NPHCE is so necessary. It captures the overlapping challenges. First, you've got the massive rise in chronic non-communicable diseases, NCDs.
Okay, like diabetes, heart disease.
Exactly. Diabetes, hypertension, cardiovascular problems, cancers, COPD, the list goes on. And the key thing, these need long-term management, constant care.
Right. It's not a one-off illness. It puts a strain on everything.
Definitely. A huge strain on resources, on families, on the individuals themselves. That's burden one.
Okay, what's the second?
The second is functional decline and related disabilities. So problems walking, major vision or hearing loss, and cognitive issues like dementia. These really impact someone's independence, their quality of life, their ability to just participate.
I can see that. And the third part of this triple threat?
That covers the social and psychological side. Things like loneliness, isolation, sometimes neglect, financial worries, even elder abuse, sadly. And from a public health view, these aren't separate issues. They directly impact physical health. They're social determinants,
It all connects.
Completely. Recognizing this whole picture is what led to launching the NPHCE back in 2010-11. Initially in 100 districts, the goal was comprehensive, dedicated, and really importantly, affordable care.
Affordable and accessible seem key for a country like India. So they saw the need for a holistic approach. What were the main goals they set out?
Well, the big overarching goal was exactly that. Accessible, affordable, high-quality geriatric care at all levels of the system.
Ambitious.
Very. But what was maybe most ambitious, especially then, was the focus on early identification through screening, not just waiting for problems. And tied to that, building the capacity of health workers, doctors, nurses, community workers, plus dedicated facilities, home-based care options, and linking health with social support.
So not just building clinics, but building skills and awareness right down to the community.
Precisely. You have to empower the workforce and the community. You can't just build buildings.
Makes sense. So how did they plan to actually do all that? What were the practical strategies?
The strategies were pretty grounded in solid public health thinking. A big one was preventative and promotive services. So health education, nutrition, how to prevent falls, mental health awareness, trying to keep people healthier for longer.
Investing up front.
Exactly. That saves so much down the line. Then, of course, curative services for when people are ill. Dedicated geriatric clinics, hospital wards, physiotherapy, even palliative care, covering that whole clinical spectrum.
Right, the treatment side. But you mentioned building skills.
Yes. Capacity building. Crucial. Training everyone from specialist doctors down to the village-level health workers, the ASHAs and A&Ms. Even family caregivers. You need people who understand the specific needs of older adults.
A trained workforce makes all the difference.
Absolutely. Then there's IEC information, education, communication, basically raising awareness in the community, fighting stigma, letting families know what support is available, encouraging people to seek help earlier.
Tackling that social dimension we talked about.
And finally, research and monitoring, collecting data, evaluating the program, making sure it adapts based on evidence. You need that feedback loop.
Data-driven decisions. Okay, this structure they use to deliver all this, the hub and spoke model, it sounds quite logical, but maybe complex in practice. Can you walk us through it?
Yeah, it sounds technical, but it's really about creating a pathway, a continuum of care. Think of it like layers. At the very base, out in the villages and at the sub-centers, you have your frontline workers, the ASHAs,
The
ANMs.
community health work.
Right. They do home visits, basic health talks, nutrition, hygiene, fall prevention is a big one.
Mhm.
And critically, they spot older people who might need more help and refer them up.
So the first point of contact, identifying risk, then what?
Then you move up to the primary health center, the PHC. They aim to have a weekly geriatric clinic there. They do screenings, blood pressure, diabetes, checks for vision problems like cataracts, hearing, depression, mobility issues. They provide basic meds, counseling.
Okay, screening and basic management. What if someone needs more than that?
Then they go to the next level, the community health center, CHC, or maybe it's sub-district or civil hospital. There, you'd find a biweekly geriatric clinic, maybe a small 10-bed ward just for elderly patients, a physio unit, better lab tests, a step up in care.
Getting more specialized.
Exactly. And then at the district hospital level, it ramps up again. A daily geriatric outpatient department, another 10-bed ward, more rehab services. And crucially, they link up with palliative care teams, NGOs, offer counseling, maybe even daycare services.
So a much wider range of services at the district level. Is that the top?
Almost. Above the district hospitals are the regional geriatric centers, RGCs. These are often based in medical colleges. India's upgraded about 20 institutes to become RGCs. Here you get real tertiary care specialists like orthopedics, neurologists, psychiatrists focusing on older adults. They have dedicated wards, advanced diagnostics, and they're also major training centers for doctors and nurses. Plus, they do research.
Ah, so the RGCs are the specialist hubs and training centers.
Pretty much. And right at the very top, there are two national centers of aging, one at AIIMS in Delhi, one in Madras Medical College in Chennai. These are the apex bodies. Think top-level training, research, helping shape policy, coordinating with everyone.
Wow, okay, that's quite a structure from village visits right up to national centers.
It is. And the beauty of this tiered approach, you see, is that it ensures basic care is widely available, but funnels complex cases efficiently to where the expertise is. It's designed for scale.
That makes a lot of sense. Now, something else that struck me was how NPHCE isn't working in isolation. It seems really integrated with other big national health programs. You mentioned links to the NCD program for diabetes, heart disease, cancer, but also mental health, palliative care, even programs for blindness and deafness.
Yes, that integration is absolutely vital from a public health perspective.
And it goes beyond just health programs, right? Links to social welfare, pensions, helplines.
Exactly. And this brings up a really important question. How does this kind of multi-sector approach actually lead to better care? Well, it means you're looking at the whole person, not just one disease. Someone might have arthritis, yes, but they might also be lonely or unable to afford nutritious food.
Right, treating the arthritis alone won't solve everything.
Precisely. You need that coordination. It reflects the understanding that health is about physical, mental, and social well-being. It's holistic. And that focus on training we talked about fits right in here. Training needs to cover not just the medical side, but also how to work across sectors, how to communicate effectively, how to understand the social context.
Training for that whole integrated system. Okay, so we have this ambitious plan, this complex structure, this focus on integration. How's it actually working out? Let's talk achievements first. The source material mentioned, over 20 regional geriatric centers established, hundreds of clinics running?
Yeah, those are significant steps. Establishing the RGCs is a big deal for specialized care and training, and getting hundreds of geriatric clinics operational at district and sub-district levels expands access considerably.
And more physio and palliative care available, too.
That's another key achievement. Plus, just bringing elderly health issues into the spotlight, making them a priority in policy discussions. That visibility matters a lot.
Definitely progress. But like any huge program, there must be challenges, too. What are the main hurdles NPHCE is facing?
Oh, absolutely. And these are the kinds of challenges you often see in large public health initiatives, especially in diverse settings. A major one is human resource shortages, particularly not enough doctors and nurses trained specifically in geriatric medicine. That impacts quality and access, especially for complex care.
The specialists are scarce.
Very. Then there are infrastructure gaps. While progress has been made, not every district has a fully functional geriatric ward or all the needed equipment yet. Sometimes the space is there, but maybe not the staff or specific tools.
And I imagine reaching rural areas is tougher.
That ties into the urban-rural disparities, definitely. Services tend to be better and more accessible in cities. Reaching remote villages with consistent quality care is a huge logistical challenge.
What about getting people to actually use the services?
That's another big one. Low community awareness. Sometimes people just don't know these services exist. Or there's stigma, especially around mental health issues like dementia or depression in the elderly.
So people might delay seeking help, or families might not recognize the need.
Exactly, which hinders early detection. Then there's financial sustainability. Chronic care, assistive devices like walkers or hearing aids, they can be expensive. Ensuring consistent funding is always a concern.
And keeping track of it all.
Monitoring issues are also a challenge. Getting accurate, complete data on elderly health problems, morbidity data is tough. Underreporting makes it hard to truly know the impact and where to adjust the program.
So workforce, infrastructure, access, awareness, funding, data, quite a list. But typical for this scale.
Pretty typical, yes. It highlights that implementation is an ongoing process of problem solving and adaptation. It's never just set it and forget it.
Right. So looking forward, what's next for NPHCE? What are the plans to tackle these challenges and innovate? I saw mention of strengthening home-based care, maybe using tech.
Yes, that's a key direction. Using telemedicine to support home-based care, empowering community health workers more, bringing care closer to people.
Makes sense. And more screening.
A big push for universal screening for NCDs and disabilities right at the PHC level for all elderly, catching things even earlier.
Proactive.
Definitely. Also plans to expand those RGCs, ideally one in every state, exploring public-private partnerships, maybe for things like affordable assistive devices,
And linking more with insurance.
integrating better with schemes like Ayushman Bharat to help with costs, and a continued strong focus on promoting healthy, aging lifestyle changes, keeping people socially engaged, creating age-friendly communities.
It sounds like they're aiming to build on the foundation and tackle those gaps. How does all this fit into the global picture of aging?
Well, what's really encouraging, connecting this to the bigger picture, is how well India's NPHCE aligns with global efforts. You have the WHO's Healthy Aging Strategy, which focuses on functional ability, participation, dignity. NPHCE hits all those notes.
So it's following international best practice.
Very much so. And it also aligns perfectly with the UN Decade of Healthy Aging, which runs until 2030. It shows India isn't just tackling its own demographic shift, but its efforts and the lessons learned are contributing to the global conversation on how we support aging populations worldwide. It's part of a shared challenge.
That's a great perspective. Okay, let's try and wrap this deep dive up. So what does this all mean? It seems clear the NPHCE is a really significant forward-thinking initiative. It's trying to ensure India's older population can live with dignity, independence, and good quality of life as they age.
Absolutely. It's a landmark program in terms of its scale and ambition.
And while we've seen there are real challenges, resources, reach, awareness, provides a solid framework, a blueprint almost.
It does. And it provides a structure to build upon, to adapt, to improve over time.
So a final thought perhaps for our listeners, many of whom might be in or heading into public health roles.
Yeah, I think this raises an important question for all of us, really. How can you, in your own work or community, apply the principles we've seen in NPHCE? It's not just about the specific model India uses. It's about advocating for that holistic view, for integrating health and social care, for focusing on prevention, for championing age-friendly approaches wherever you are.
Thinking about the underlying ideas.
Exactly. How do we ensure dignity and support for older people in our own context? The lessons from large programs like this, both successes and struggles, offer really valuable insights into the human side of delivering healthcare and building supportive societies for all ages. Keep digging into healthy aging. It affects everyone.